Good morning, everyone. Hope you all stay safe at home during this COVID-19. Let us discuss today regarding the topic intermediate uveitis. All of you already are aware about and anatomy of the uveal tract. And coming to the intermediate uveitis, pars plana is the structure you need to know. It's a flat extension from posterior aspect of ciliary process to hora serrata. It's around 3.5 to 4 mm in length, around 3 mm from limbus, that is ciliary process. As you already aware of the classification of the uveitis, anterior, intermediate, posterior panuveitis. According to the International Uveitis Study Group, which is the primary site of inflammation according to the classification. In anterior uveitis, primary site anterior chamber. In intermediate uveitis, vitreous. Posterior, it is retina and right. And panuveitis, as the name itself says, pan means all the structures we come across. Intermediate uveitis is described as inflammation in the anterior vitreous, pars plana, and peripheral retina. But when you talk about the pars planitis, it should be used only for the subset of intermediate uveitis where there is no bank or a snowball formation occurring in an absence of an associated infection or systemic diseases. These are the nomenclature cyclitis, peripheral pars, which is found out by the respective authors during a particular year. You can, just for your knowledge sake, you can go through it. Coming to the epidemiology, the incidence in population 1 in 15,000, and when it comes to the male to female ratio, almost is equal with the mild male domination. And the average age is around second to third decade. Usually, you can get unilateral as well as bilateral, whereas bilateral uveitis 70 to 90% you get bilateral uveitis. International uveitis study group suggested idiopathic inflammatory syndrome, mainly involving the anterior vitreous, peripheral retina, and ciliary body with minimal or no anterior segment or chorioretinal sign. Coming to etiopathogenesis, most of the time we call it as idiopathic, but may be initiated by an unknown antigen, leading to clinical picture of vasculitis and vitreous cells. And coming to the intermediate uveitis, seems to be usually T-cell mediated diseases. And coming to the histopathological study, you see usually peripheral retina and the ciliary body demonstrate the condensed vitreous fibroblasts, spindle cells, lymphocytes, blood vessels, and prominent lymphocyte cuffing of retinal veins. Clinical features, which is intermediate uveitis, is the most underdiagnosed disease. Why? Because of lack of routine examination of the pars plana and also the lack of awareness. Why? Because in intermediate uveitis, most of the time eye looks quiet. So, still there are some symptoms and signs you can elicit in intermediate uveitis. What are the most common symptoms you get in intermediate uveitis? Most commonly, they say the floaters, mild blurring of vision, mild photophobia, whereas pain and redness is uncommon, where in anterior uveitis most commonly the patient come with the pain and redness. Coming to the signs, most of the time eye looks quiet. Still, to some extent, you can elicit a mild congestion. In anterior chamber, there may be no or minimal findings. To some extent, inferiorly, you can elicit some cells, flare, and fine KPs. Or depending upon the etiology, you can find the other KPs also. And posterior synechium. Because when you look at, usually you find vitreitis, which is a characteristic feature of intermediate uveitis. And again, how you classify aqueous layer, even vitreitis you can grade or stage 1, 2, 3, 4 plus depending upon the haze. Kindly go through this diagrammatic and a table given. And when you look at the fundus, you see a characteristic mobile globular yellow-white snowballs seen in the inferior peripheral vitreous. They lie close to retina but are not in contact with it. Inflammatory exudate accumulate over pars plana to form snowbank. Periphragmitis of peripheral veins in vicinity of exudate. The later, the vitreous also show degenerative changes with fiber-like cylindrical condensation of coarse vitreous strands, which will later stage gives a room for posterior vitreous detachment. Retinal changes in the inferior intermediate uveitis include tortuosity of the arterioles and venules, sheathing of peripheral veins, neovascularization, and retinal detachment. Cystoid macular edema. The hallmark of pars planitis are posterior hypopyon and snowbank, and the exudates are periretinal, peripheral, typically inferior, but may also be superior or divided into multiple foci or extend 360 degrees over the entire pars plana. So the anterior vitreous, you can see the snowballs, pars plana, snowbanking. So coming to the differential diagnosis, you have a differential diagnosis depending upon whether it is infectious or immune related, and most commonly idiopathic and systemic associated like syphilis, Lyme disease, multiple sclerosis, sarcoidosis, and less commonly could be due to lymphoma, HTLV, toxocara, and sets. So with the prominent signs, you can correlate some of the most common differential diagnosis. For example, if you have a vitreous opacity, most DD comes to your mind would be posterior uveitis, endogenous endophthalmitis, amyloidosis, reticulum cell sarcoma. If you see, most commonly perivasculitis could be a Heels, sarcoidosis, or Behcet's. Peripheral granuloma usually could be toxocara, and spillover anterior uveitis, most commonly you go for non-granulomatous anterior uveitis. So these are the most common systemic associated intermediate uveitis like multiple sclerosis, intraocular lymphoma, sarcoidosis, syphilis. And coming to the diagnosis, usually based on the clinical findings and the patient history, should be a prime focus to know whether it is primary or a secondary or acute or chronic, depending on the duration, symptoms, number of recurrence, and findings that might be associated with a particular systemic correlating disorders. Along with the clinical presentation and the history, duration, recurrence, and ancillary test plays a very important role, like a fundus fluorescent angiography, ultrasonography, ERG, UBM. These will give the complication correlating with the associated intermediate uveitis. And other lab investigation to go for a particular associated systemic disorder or disease associated, like baseline investigation, CBC, ESR, renal function test, liver function test, and BPD test, chest X-ray. And if you suspect a sarcoidosis, CT lung, AC enzymes gives a particular diagnosis, and serological test, VRL, FDA antibodies and Lyme's, and HLA associated, and vitreous tapping. And most common complication associated with the systemic disorders, most common complication associated with the intermediate uveitis is cystoid macular edema, complicated cataract, glaucoma, optic disc edema, optic neuritis, neovascular disc neovascularization elsewhere, and venous sheathing. Most of the time it is benign, and vasculitis and retinal detachment. Most common you see serous and rigmarous type of retinal detachment. Treatment, coming to the treatment, as a four-step approach by Kaplan, it plays a very important role and gives a good treatment protocol for the intermediate uveitis. Step 1, when you diagnose intermediate uveitis, you can go straight away start subtenon injection of the steroids, preferably in the upper temporal quadrant. Suppose if it fails, you can switch on to step 2, where you can start cryopexy. So mechanism, what is the cryopexy mechanism? It's a restriction of the hyperemic vascular component of the diseases by eliminating neovascular and ischemic tissue. Suppose even cryopexy doesn't respond, you can go to switch on to step 3, where you can do pars plana vitrectomy. It helps in resolution of cystoid macular edema in early duration. Step 3, suppose not helping, you can switch to step 4, where you can start the immunosuppressive agents like cyclophosphamide, azothioprine, chlorambucil. You can start, which helps in treating the cystoid complicated associated intermediate uveitis. The current guidelines in many institutions follows this. Kindly go through this flow chart, and then this associated complication like glaucoma you need to manage, and treatment of the cataract, that is complicated cataract, you need to treat. And if you find NVD or NEV better, we have to switch on to anti-VEGF intravitreal injection and supportive and placebo therapy to be done for intermediate uveitis. Thank you.